Percutaneously assisted EUS-guided gastrojejunostomy for the treatment of afferent limb syndrome. Keyword: organ, stomach jejunum, procedure, EUS-guided gastrojejunostomy, diagnosis, afferent limb syndrome, therapy, EUS-guided gastrojejunostomy, instrument use, endoscope, EUS scope, accessory use, lumen apposing metal stent, CRE balloon. Afferent limb syndrome is a postoperative complication of gastrointestinal surgery, Bilirubin Roux-en-Y reconstruction, or pancreatoduodenectomy. The incidence in post-Bilirubin or Roux-en-Y reconstruction is from 0.3 to 1%. In post-pancreatoduodenectomy is 13%. The most common clinical presentation is obstructive jaundice or cholangitis. Symptoms are attributed to the increased intraluminal pressure and distension due to accumulation of enteric, biliary, and pancreatic secretion in the obstructed afferent loop. The treatment could be performed through percutaneous drainage, surgery, or endoscopic treatment with techniques such as endoscopic dilation, enteral stent placement, or lumen apposing stent assisted treatment. There is a 72-year-old female with history of pancreatic mass in the head of the pancreas, status post-pancreatoduodenectomy in October 2014. The final diagnosis was a moderately differentiated adenocarcinoma, T3N1. The patient underwent adjuvant therapy with chemotherapy for 6 months and radiotherapy. 17 months after pancreatoduodenectomy, she presented with fever and jaundice. Labs were consistent with leukocytosis, a total bilirubin of 5.9, alkaline phosphatase of 277, and E. coli bacteremia. On admission, a CT scan without contrast was performed. There was dilation of the afferent limb described as a C-loop related to the gastrojejunostomy. The intra and extrahepatic ducts were also dilated and there was ascites. These radiologic findings were consistent with afferent limb syndrome and they were highly suspicious for pancreatic cancer recurrence. ERCP at outside hospital could not be performed due to high-grade stricture at the afferent limb. Percutaneous transhepatic biliary drainage was placed. Upper endoscopy was performed. There were 2 limbs at the gastrojejunostomy. The efferent limb was widely patent. There was a high-grade stricture of the afferent limb and the endoscope could not be advanced. Contrast was injected into the afferent limb lumen. Fluoroscopy revealed a 10 cm long stricture. An hydrophilic wire could not advance through the stricture. At this point, a decision was made and a mixed solution of saline, contrast, and methylene blue was injected through the PTC drain to distend the afferent limb. On EUS, there was a dilated jejunal loop. The afferent limb was endosonographically located. Then, it was targeted with a 19-gauge FNA needle. A blue solution was suctioned from the punctural loop, confirming a good position of the FNA needle. Then, through fluoroscopic guidance, an hydrophilic wire was advanced to the afferent limb lumen. A lumen apposing metal stent and electrocautery enhanced delivery system was advanced over the wire from the stomach lumen to the afferent limb lumen. Then the distal phalange was deployed under endosonographic guidance. The proximal phalange was deployed under endoscopic visualization. The gastrojejunostomy tract was then dilated with a CRE balloon up to 12.5 mm. Contrast was injected into the stent lumen, demonstrating a wide communication with the afferent limb lumen. Follow-up. The patient progressed with improvement of symptoms. An upper GI series demonstrates the lumen apposing stent in place without evidence of leakage. Technique highlight. The advantages of the technique are minimally invasive procedure. The existence of an external biliary fistula allows instillation of a mixed solution of contrast, saline, and methylene blue into the obstructed afferent loop, facilitating endosonographic confirmation of the target for needle puncture. In conclusion, endoscopically created gastroenteric anastomosis is a safe and an effective procedure for relief of an afferent limb syndrome.